is our discussion of paternalism as it appears in this chapter on the principle of beneficence. Debates over paternalism are quite prevalent in bioethics, which is why we're going to end up devoting a full week to it later in the semester. But here we just want to define what paternalism is and look at a pretty common distinction between soft and hard paternalism. And then we'll talk about situations in which we might be justified in denying procedures if they're non-beneficial. So paternalism can be defined in a number of different ways because ultimately we want to make sure that we are catching the cases that we think we need to and making sure that we aren't mislabeling other cases as paternalistic when they aren't. And this is something that Beecham and Childress talk about. So here I'm just going to provide you with Beecham and Childress's preferred definition that they give towards the end of this section on the nature of paternalism. So they define it as the intentional overriding of one person's preferences or actions by another person, where the overriding person justifies this action by appeal to the goal of benefiting or of preventing or mitigating harm to the person whose preferences or actions are overridden. That sounds like a lot. So let's talk about a couple of examples, or I'm going to talk through one and then I'm going to list the ones that they give you in the reading. And I think it should be obvious from there. But I don't always talk about the memes that I have on these slides, but I'm going to talk about it this time because I'm going to assume that most of you are familiar with the Harry Potter saga, and this is a really good example of paternalism in action. So if you remember, what was it, sixth movie? I have not read all the books. I guess I'm behind on that. But I think it's whatever the sixth book was, and Harry is they went to this cave to get this Horcrux thingy, and Dumbledore says that he has to drink this whole potion, but it's going to make him go mad, and it's Harry's job to force him to keep drinking it, even though he's not going to want to. YouTube it if you haven't seen it. But the whole idea here is that Harry is forcing Dumbledore to keep drinking this potion, even though Dumbledore doesn't want to. The reason why Harry is forcing Dumbledore to do it, one, which we'll talk about on the next slide, is about autonomous decision making. But the second one is because Dumbledore told Harry that he needed to drink the whole potion for him to get better. So Harry is trying to mitigate these harms that Dumbledore is experiencing by overriding the wishes that Dumbledore is expressing here. So that's a pretty classic example of paternalism that you might know from popular culture. But within the bioethics sphere, Beecham and Childress give us a number of examples. I'm just going to read them off to you here. So blood transfusions when patients have refused them, involuntary commitment to institutions for treatment, interventions to stop suicides, resuscitations of patients who have asked not to be resuscitated, withholding of medical information that patients have requested, denial of an innovative therapy to someone who wishes to try it, and then also some governmental efforts to promote health. So those are all different examples of paternalism where it's the case that the healthcare provider is trying to intervene in such a way because they think that it's for the benefit of the patient. Whether or not that's true, whether or not that's justified, that's what makes this a very complicated issue, which we'll talk a little bit more on the next slide when we differentiate between hard and soft paternalism. But I think just to connect this to something else that we've talked about in a previous lecture. So if you remember when we were talking about informed consent and this idea about non-control, freedom from influences. So influences can be manipulation, persuasion, or coercion. And so here, Beecham and Childress say that paternalism sometimes uses forms of influence such as deception, lying, manipulation of information, non-disclosure of information, or coercion. But they may simply involve a refusal to carry out another's wishes. And we'll return to that once we talk about these non-beneficial treatments later. But so this is the sort of purview of what we are considering when we're talking about paternalism. So the distinction between soft paternalism and hard paternalism is quite important when we are thinking about the larger framework that Beecham and Childress are providing us with all 4 principles. So soft paternalism and hard paternalism differ with respect to how the principle of respect for autonomy is at play. So soft paternalism occurs when we intervene in the life of another person on the grounds of this principle of beneficence or the principle of non-maleficence with the goal of preventing substantially non-voluntary conduct. So there the key term is non-voluntary. So this is not necessarily a decision that the patient is making that would constitute an autonomous decision. Hard paternalism, on the other hand, is the idea that we are intervening even though the patient has the capacities that are associated with autonomous decision making, and they can still make these decisions themselves. So we get a couple of other sort of clarification points here from Beecham and Childress about this distinction. So soft paternalism actions are morally complicated, largely due to the difficulty of determining whether a person's actions are substantially non-autonomous and of determining appropriate means of action. So when it becomes a question about whether or not somebody has the capacity for autonomy, if you remember when we were talking about testing for competence, and I told you how that is a lot trickier than you might first think, this is what Beecham and Childress are talking about. How can we be sure that the conduct is non-voluntary? And one of the papers that we'll read on paternalism will pick up on this point when it comes to the practice of psychiatry, because there are a lot of times in which patients don't think that they are sick or have an ailment, and the psychiatrist says, no, you just are not perceiving it. And so this issue about determining if a patient has the autonomous decision making is fraught with complications, but at least with soft paternalism, there's no deep conflict between the principle of respect for autonomy and the principle of beneficence, because in these situations, the patient doesn't necessarily have autonomy, so we can't really be violating it if they don't have autonomy. Here, soft paternalism is a pretty modest intervention, because it only tries to prevent the harmful consequences of a patient's actions that the patient did not actually choose with substantial autonomy. Hard paternalism, on the other hand, usurps autonomy by either restricting the information available to a person or overriding the person's informed and voluntary choices. They also go on to talk about paternalistic policies, and the question then becomes, is hard paternalism ever actually justified? And you might think, well, it seems wrong to ever violate somebody's autonomy, and I think that intuition is a good one in most circumstances. And this is the point in which I again have to stress that none of these principles necessarily are prioritized over one another. But that also means that the principle of beneficence or non-maleficence doesn't always beat out autonomy. You're not, it's not defensible to always violate a patient's autonomy because you think you know what's right. Instead, Beecham and Childress give us a couple of guidelines about when hard paternalism might be justified. So they give us this case about seeking a second test because you are sure that the results would cause a bunch of or some pain for the person who the tests are for. So imagine that you get an unfavorable diagnosis, or you're going to have to give an unfavorable diagnosis based on a test, and there is a chance that the test could be wrong, and so you don't want to cause this unnecessary hardship for the patient. It seems like in that situation, withholding the test results until another test can actually be administered, that seems to be justified in a certain way. And again, we'll talk about this with the other paper, the nocebo effect paper that we'll discuss when we get to the paternalism week. But Beecham and Childress then go on that say that even hard paternalistic actions can sometimes be justified, and they're justified in healthcare only if the following conditions are satisfied. So a patient is at risk of a significant preventable harm. The paternalistic action will probably prevent the harm. The prevention of harm to the patient outweighs risks to the patient of the action taken. There is no morally better alternative to the limitation of autonomy that occurs. The least autonomy restrictive alternative that will secure the benefit is adopted, and a paternalistic action should not damage substantial autonomy interests. So in general, as the risk to a patient's welfare increases, or the likelihood of an irreversible harm increases, the likelihood of a justified paternalistic intervention correspondingly increases. So this is just to say that as the stakes get higher, there seems to be a case to be made for hard paternalism, or a stronger case to be made for hard paternalism. But I just want to stress here that I'm not saying that as a healthcare provider, if you're in the situation that hard paternalism should win out more times than not. I vehemently caution you against that. That is the type of behavior that you see on medical TV shows, where you see these rogue doctors just making the decisions for the patients. Instead, again, our job here is to look out for the best interests of the patient. At least that's how Beecham and Childress are selling this. And again, we're reading Beecham and Childress because they're sort of the foundation for which people respond to. You don't necessarily have to accept Beecham and Childress's positions. You can argue against them. You can provide your own reasons for accepting or rejecting their arguments. But I think the sentiment that runs through all of Beecham and Childress's chapters and all of their work here is trying to act in the best interests of the patient. And sometimes that means violating their autonomy, but most times we are looking for the best way to uphold their autonomy, to provide them with the information that they request and make sure that we respect their wishes, because at the end of the day, we do intuitively, our considered moral judgment is that people should have some measure of control over their own life. So again, this is just more about the distinction. I'm trying to harp on this one more time because I don't want you to leave this class thinking I can justify always intervening in whatever way that I see fit. Instead, it's about how do these different principles interact with one another, and can we provide justification on the basis of one to have that normative dominance, if you remember from that first week from Vaughan, right? Which one has normative dominance in certain cases, and can we provide cogent moral reasons for arguing for one principle over another? Let's finish up by talking about non-beneficial procedures, because this is another case where paternalism is at play. So the question is, if a patient requests a procedure that is deemed non-beneficial, are you obligated to provide it? Hopefully you remember from our previous discussion about futility, I'm just going to go ahead and put this up here, that Beecham and Childress argue that in cases that are genuinely futile, you are not obligated to provide a certain treatment. And so imagining that a patient requests some treatment that they read online that you don't think is going to be beneficial, and you refuse to provide that treatment for them, this is a case of passive paternalism. It happens when professionals refuse to execute a patient's positive preferences for an intervention on the basis of beneficence, because ultimately it's not beneficial for the patient. And if it's not beneficial for the patient, then it doesn't seem like it's it's not morally obligated for the healthcare provider to provide it, because especially it might lead into false senses of probably like therapeutic optimism, and that whole idea where you think that you're going to get better just because you're receiving a treatment, and you have this idea that just because you saw it online, right? Typically those treatments can carry negative consequences, and as a healthcare provider, if you think that it's going to run counter to your responsibility to uphold the principle of beneficence, Beecham and Childress say that you have a, don't know if I want to say right, but you are not morally obligated to provide that treatment. I'm just going to stick with that phrasing. And so talking about this whole idea about medical futility and clinically non-beneficial interventions, the reason why I bring that up is because if you remember from before, when Beecham and Childress were talking about the idea of futility, and it's difficult to ultimately decide when something has become futile. And so here, Beecham and Childress suggest using this phrasing instead to communicate that it's the beneficial aspect or the non-beneficial aspect of the treatment that is ultimately the reason for not providing it, because it's ultimately not up, or it's not consistent with the principle of beneficence. Now let's just do our customary summary. Paternalism occurs when a healthcare provider intervenes intentionally to override a patient's request on the basis that that request is not consistent with their own benefit or receiving a certain benefit. And so we differentiate between soft and hard paternalism. Soft paternalism occurs when a patient is unable to make autonomous decisions, or their decision or request for treatment or information is non-voluntary. And then hard paternalism is when a patient does possess the capacity to make autonomous decisions, but we still override, I guess I shouldn't say we, their interests are, or not their interests, I don't want to say that. Their decisions are overridden because we're looking out for their best interests. There we go. That's the important point to take home here, which is that hard paternalism isn't about affirming your knowledge over the patient. It's about acting in such a way because you are most concerned with the patient's best interests. That's the take-home message about hard paternalism, and that seems to be the only cases in which it is justified, and it requires a strong justification to violate somebody's right to autonomy. That's what Beecham and Childress are really trying to drive home, not that rogue doctoring or healthcare providing is the way to go. So just want to stress that one more time. And then we just talked about passive paternalism, which is when a healthcare provider refuses to fulfill a patient's preference because it's actually not going to be beneficial for them. Again, this is consistent with the principle of beneficence because we are trying to benefit the patient, and if we just provide them with non-beneficial treatments, then in that case, we might end up playing into a situation where the patient is actually going to be harmed by receiving that treatment. And as I've been mentioning throughout this presentation, we will return later to this topic of paternalism. It's impossible to cover it all in one go, and we're not going to cover it all in that second week either, but I just wanted to show you some more dimensions of paternalism later on, so to be continued.